Hey friends, I'm really excited to be making this video as it's all about a treatment method that's new to me and that I've been using successfully with my patients. Please watch this until the end because the information in this video is super important and I wish I knew it all 5 years ago at least or more. Watch on a faster speed if you have to. I don't care if you don't care that I sound like a chipmunk, but I do think it's important to get all the information in this video, whether you are someone who's suffering from TMJ, TMD, which is most of my audience, or whether you're a dentist or a practitioner trying to learn more about how to treat this successfully. Again, please try not to miss any of this as it may help you or someone you love who is suffering from TMD, from trigeminal neuralgia, or from Meniere's disease. Yep, all three, my friends. This video is all about the TScan Technology and DTR, which stands for Disclusion Time Reduction Therapy. DTR and TScan are used for chronic muscular TMD pain. So what does all this mean? Well, my friends, the process of Disclusion Time Reduction Therapy, which utilizes TScan 10 measurements and muscle activity measurements, was developed by Dr. Robert Kerstein 35 years ago. So even though this is new to me, the TScan technology and DTR, those are not actually new therapies. Before we really get into this, I want to take a moment to thank Dr. Robert Kerstein and Dr. Ben Sutter for helping me to write this very, very important content. I wanted to make sure that everything in this video is factual, so I went to the DTR TScan masters themselves. So thank you both for your time and for your efforts. So let's get right into it. The disclusion time was discovered in 1987. I was 4 years old then, with the TScan 1 technology. The disclusion time is the time it takes to go from your habitual bite, your normal bite, all the way right or all the way left with your teeth gliding against each other. So watch me closely as I show you this. Bite down hard, your normal natural bite. The disclusion time is the time it takes to go from there all the way to the left with your teeth gliding against each other. And then again, all the way to the right with your teeth gliding against each other. The TScan 1 was the first occlusal computer a patient could bite into that recorded 16 relative bite force levels changing across 3 seconds of time. And the recorded bite could then be played back in a 3-second force movie video. Pretty cool, huh? It was TScan 1's timing capability that significantly improved the understanding of both of the following. 1, how simultaneous and balanced contacts were when we close into our habitual bite. So it's looking at the force, the relative bite force in our bites. And 2, how long during sideways jaw movements the patient's biting surfaces caused back teeth to rub together before those teeth came apart during those same side-to-side jaw movements. It was later discovered that when the disclusion time was long, greater than 1.4 seconds, it caused high jaw muscle activity and chronic TMJ pain. But when the disclusion time was shortened to less than 0.5 seconds, 0.5 seconds, by a specific TScan 1 guided bite adjustment process, the muscle activity in the painful TMJ muscles was removed, and so were the painful TMJ symptoms. Crazy, huh? So, to repeat and to clarify, the time it takes to go from here to here, or here to here, should be 0.5 seconds or less without back teeth causing interferences. As you glide right and left, if you feel your back teeth contacting, that's not a good thing. Since 1991 and up to 2024, this year, DTR treatment, disclusion time reduction treatment, has been extensively studied and repeatedly validated as being highly effective in resolving chronic TMD in many, many published studies. Pretty amazing, right? The TScan 10 is a biometric technology that uses very precise piezoelectric flexible mylar sensors to measure 256 different relative levels of bite force. The sensor itself is 0.1 millimeters thick. That's 100 microns, which is very, very thin. For perspective, there's 1,000 microns in a little bitty millimeter. So the sensor is very thin. And again, the sensor measures relative bite force. Take a look at this image. You can see the dental arch and you can see how the teeth are hitting. Blues and greens, those bars rising up from the teeth or from the arch diagram, indicate lower relative bite forces, and pink indicates a high force of unknown quantity. So one pink bar here may be ceiling level, another may stop just beyond the screen, and while even another may be just a tad higher than a red or an orange force level. You can also see the percentage of bite force per tooth. So if a few teeth are taking an immensely high force day after day, month after month, year after year, eventually those teeth will crack and break. Once a tooth cracks or breaks, usually a crown and sometimes even a root canal will be needed. Both of these procedures require removing millimeters of enamel to restore the tooth. So 1,000 microns, 1,500 microns or more to prepare that tooth for a crown. With DTR, we sacrifice mere microns of enamel to balance the bite force and calm the muscles down. This also saves millimeters of enamel later as it prevents teeth from breaking. Along with measuring bite force, disclusion time reduction also involves measuring muscle activity. How much the muscles are firing when the teeth come together into the habitual bite. Dentists, we call this MIP, maximum intercuspation. DTR is also measuring how much the muscles are firing with side-to-side movement. We have a lot of that side-to-side movement with chewing and with grinding our teeth. The muscles should fire, yes, but not to the degree where the firing levels can cause pain, dizziness, problems with chewing, problems with speaking, and more. So let's review. What does DTR mean? Again, disclusion time reduction. The disclusion time is the amount of time it takes to move from your normal habitual bite position all the way right out to your canine tip, and then again from your habitual bite all the way left out to your canine tip. Watch as I demonstrate. If this time is longer than 0.5 seconds, that means that the back teeth are likely getting in the way and gnashing against each other. This can either hyperactivate the muscles or exhaust them so much that they become underactive, both of which are problems and can lead to pain and discomfort. So now that you know what the disclusion time is, disclusion time reduction is the therapy that reduces the time it takes to move your teeth from your natural habitual bite all the way right or all the way left in less than 0.5 seconds. This is done with very precise, data-driven micro adjustments made to the teeth. It involves removing microns of enamel with a dental handpiece to balance the bite, remove the side-to-side friction, and relieve the muscles. This is done in real time with bite force measurements and muscle activity measurements, simultaneously taken all throughout the process. Those measurements guide us where to reduce forces and shorten the disclusion time. Those measurements guide us to exactly which teeth need those micro adjustments. And if you're afraid of removing enamel on your teeth, think of it this way. The burr that we use when we make these micro adjustments is actually not a cutting burr. It's sort of like an emery board. It's like a filing sort of thing. So it's almost like filing your nail and just making it a little bit smoother. It's a light dusting on the teeth, guided by where that's needed by the measurements on the computer, and it can have an enormous impact on your muscles and on your nerves. What's amazing about all of this is that you can see a physiologic change. You can see the muscle activity go down as you do this because you're measuring it as you go along. Now, some people are opposed to removing enamel. This therapy is all about micro adjustments. The theory is to sacrifice a few microns of enamel now to save millimeters of enamel later when the tooth breaks due to such high relative bite force. Here we are using not a cutting burr when we do the adjustments. We're using, it's almost like an emery board. When you're filing your nails, that little amount of dust that comes off or powder that comes off, that's similar to what we're doing rather than drilling into your tooth. And keep in mind that these micro adjustments also calm down the muscles and the nerves. Now let's take a moment to nerd out and talk about the science here. Now we are taught in dental school to adjust the bite using bite paper and looking at the size of the marks, and the bigger the mark, the bigger the force. But get this, mark size and bite force only correlate 14% of the time. What? That means that 86% of the time, mark size and bite force do not correlate. What the what? That means that using that bite paper and what we learned in dental school, that means that we've been adjusting with 14% accuracy. That's just not good enough for patients. It's not good enough for your well-being. It's not good enough for your muscles, for your nerves, for your bite, or for dental implants or crowns to survive long-term. Can you imagine if eye doctors were only 14% accurate when performing an eye surgery? People would go blind. Can you imagine if orthopedic surgeons were only 14% accurate when performing a knee surgery? Forget about walking properly. The point here is that nothing, including dental work, should be done with 14% accuracy, especially not when there's a much better and much more accurate option. TScan Technology measures relative bite force with 95% accuracy. What would you rather have? Would you rather have adjustments on your teeth made with 14% accuracy or 95% accuracy? I think the answer is clear. I've also learned through all of this, and I've been on this journey since about June of this year, so it's relatively new to me. I've learned that occlusion, your bite, the way your teeth come together, is actually the #1 causative problem of TMD issues. Now, this was a hard pill for me to swallow because I've been practicing off the premise that clenching, grinding, sleep apnea, hormones, hypermobility, postural discrepancies, all of these played pretty equal roles, maybe with clenching and grinding being at the top in terms of what caused TMD. It's not until I was introduced to TScan and DTR that I realized that the bite plays a significant role than all of those other factors that I just listed off. But if there's one thing I've learned, it's that no one, including me, knows everything. And we must all keep learning and pushing ourselves to a higher standard for our valued patients, right? So you all deserve the best. That's why I'm on this ever-learning quest. So let's nerd out some more. DTR works neurologically from within the central nervous system to control and decrease the jaw muscles' hyperactive response to prolonged back tooth friction when moving the jaw side to side. Basically, when you move your jaw from your normal bite, right or left, we don't want back teeth touching during that movement. We don't want them getting in the way. The friction of the back teeth during those movements is what causes the muscles to become hyperactive. And I've seen this measured time and again as I've been using DTR at my office. The hyperactivity of these muscles or the overexhaustion of these muscles can lead to pain or discomfort. A long disclusion time, which we don't want, elevates muscle activity. This causes muscle ischemia, lack of oxygen, which then leads to chronic TMD symptoms. So if you've been suffering for a long time, over 6 months with constant pain, it's more of a chronic condition. If this is all new to you, it's more of an acute condition. Let's nerd out on the science some more. The back teeth have the most unique peripheral nerve anatomy. The back teeth nerves, both inside and outside of these teeth, are the only peripheral nerves that synapse inside the central nervous system. Other peripheral nerves actually have a stop-off or another synapse outside the central nervous system, and then they go on to the central nervous system. But the back teeth go directly there. Their first synapse in the CNS, in the central nervous system, is with motor fibers to the swallow mechanism muscles. So your bite directly influences swallowing. That's why TMD patients sometimes have difficulty swallowing. There's also posterior nerve fibers that travel to the reticular formation in the center of the brain. The reticular formation controls balance, posture, swallowing, digestion, and more. Basically, every time your teeth come together, the nerves are communicating with your central nervous system. This is huge. Our teeth come together 1,000 times a day just to swallow. Then add in chewing, clenching, grinding. Some of us have our teeth together a lot. Another thing we are taught in dental school is that molars should take the most force because they're bigger. They have the most roots and they're located near the center of rotation of the jaw. But actually, molars need less force to operate physiologically because they have the most innervation, as they have the most roots. Molars have 3 or 4 roots compared to 1 or 2. Because of this, molars have the largest surface area of nerve tissue both inside and outside the teeth. So too much bite force causes molars to hyperfunction the jaw muscles. The DTR procedure lessens back teeth bite forces. This controls the muscle firing by minimizing the back teeth nerve response. So who could benefit from DTR treatment? First and foremost, you must be a candidate. When your teeth come together into your habitual bite, the front teeth must touch. Preferably, canines touch each other and these canines touch each other. Additionally, your jaw joints have to be intact structurally. They can pop and click, but your jaw cannot be locked closed. Lastly, you cannot have your lower wisdom teeth erupted into your mouth where you're chewing on them. Those are kind of the main requirements that make you a candidate. Those with TMJ, TMD pain, trigeminal neuralgia, and Meniere's disease can all benefit from this treatment. The success rate for me is about 85% of those with TMD. I don't have a success rate for trigeminal neuralgia or Meniere's disease yet because I haven't really treated patients with those diagnoses with DTR and the TScan. Having said that, though, Dr. Ben Sutter, who has been treating with DTR for 10 years, celebrates a 92 to 94 success rate with trigeminal neuralgia, Meniere's disease, and TMD, regardless of the diagnosis. An interesting thing to take note of here is that it's widely accepted that trigeminal neuralgia is caused by vascular compression, that an artery or blood vessel nearby is actually compressing or pushing on the trigeminal nerve. The treatment for this is a surgical procedure called microvascular decompression, MVD. This surgically separates any blood vessels that are compressing the nerve. So it moves the blood vessel away from the nerve, thereby relieving the pressure on the nerve and reducing the pain. But get this, only 10% of cases of trigeminal neuralgia have clear underlying reasons: tumors, multiple sclerosis, or vascular compression. That means 90% of trigeminal neuralgia cases are idiopathic. Idiopathic means we don't know the cause. Also, trigeminal neuralgia occurs and recurs even without vascular compression. This means trigeminal neuralgia still happens even when the trigeminal nerve isn't compressed by a blood vessel. And 99.4% of people with neurovascular compression will not have or experience trigeminal neuralgia. Crazy, right? So what does that mean? It means that, broadly speaking, the medical community doesn't really understand that the cause of trigeminal neuralgia is usually the occlusion and not vascular compression. Crazy, right? I can't help but think that if trigeminal neuralgia can be treated with a high percentage success rate using DTR, then maybe it's more closely related to TMD than we thought. Or maybe some cases of trigeminal neuralgia are just another manifestation of TMD. So let's take a moment to talk some success stories. Let's talk about a patient of mine named Jen. Jen's main concerns when she began treatment with me were jaw pain on the left side that was constant, daily headaches, chewing pain so much that she was taking 3 Aleve per day, 1 after each meal, neck pain, ear pain, stuffy ears, and a limited range of motion. When Jen began treatment with me, it was before I had any knowledge or training of TScan and DTR. So I treated her with my normal treatment modality, a daytime orthotic and a nighttime orthotic, followed up by a lot of soft tissue therapy, manipulation, and orthotic adjustments. She tried this method for about a year, and in that time, her ear pain and neck pain resolved, but her jaw pain, headaches, and her number one concern, the pain with chewing, never went away. So we switched things up when I learned all this, and I offered to do DTR with TScan for Jen after ensuring that she was a candidate. After the first day of all TScan guided adjustments, all of her pain with chewing went away. Amazing, right? She stopped taking Aleve. But we think that because of that, that brought her headaches and jaw pain to the forefront. So those definitely remained. After her second TScan adjustment, her headaches went away and her jaw pain went down. This is amazing, right? Jordan is another lovely patient of mine who tried the orthotics for over a year. In that time, we saw a lot of fluctuation with her symptoms. There were times where she was symptom-free, and there were times where she would have an acute flare, and that would be incredibly painful for her. Jordan's main concerns when she started treatment were jaw pain and swelling, limited range of motion, tooth pain and sensitivity, her bite being off, stuffiness in her right ear, sharp ear pain, pain with chewing, neck pain, and headaches. One thing that resonated through the months she's been in treatment was that she always said her bite was off. And because orthotics take the bite out of the equation when wearing them, I didn't think too deeply about this. Once I was introduced, though, to DTR and TScan, it really got me thinking. So I evaluated her bite and saw that she was a candidate for DTR. Before our DTR session, many of Jordan's symptoms returned. She was in severe pain. We were emailing over the weekend. We were communicating on how to lower her pain. She had jaw pain, tooth pain, sensitivity. Her bite was off. She had headaches, neck pain, pain with chewing. And after 1 DTR sessions, her pain went from 9 out of 10 to 1 out of 10. She's feeling way better, and she's not clenching during the day anymore. How I wish I had known about this sooner. So I'm happy to say that I'm DTR certified now. And if you want to find a DTR certified dentist in your area, you can go to the website linked in the description box. The website will show you the dentists by country who are certified in DTR and who are not. It takes a lot of training and knowledge to get DTR certified, so please don't see someone who is not. So I know this video was chock full of information. If you have any questions, sound off below. Don't forget to subscribe, and remember, you can never have TMI about TMJ. Thank you.